Those are great photos, Bob, and a fantastic survey of the field of telemanagement. Definite evidence you presented to us there about improved therapeutic outcomes from telemanagement. Let me open the floor to any questions for Dr. Bourge.
Yes, Todd.
So one of the interesting challenges when you have a lot of these implanted devices, you're suddenly getting a huge amount of data from people that we didn't have before. How do you go about distinguishing in that case what's normal if you're not getting the same kind of data from healthy people?
Very good question. In fact, what's normal to one patient is different to another. Indeed, we have suggested normal ranges for all of these devices. With the Chronicle device, for example, we used it in a non-randomized fashion in over 100 patients for 4 years to determine what we thought was normal, because we never had this data before. We didn't know what was normal. We developed what we thought was normal variables, but it depends on the patient. For example, a patient who has diastolic dysfunction, a very stiff heart, needs a higher pressure than a patient who has systolic dysfunction, a higher intracardiac pressure. If you suddenly try to lower the pressures too much, the patient will often pass out or develop renal failure. So it depends on the underlying diagnosis, and that's why pathways are very, very critical in the application of this data. Computerized analysis of the data is also very important. What I didn't show is a computerized algorithm which we developed, which is almost, but not quite as good as someone experienced, like me, looking at the pressures and detecting when the physician or the clinician needs to look at the pressures. I have right now 42 people with these devices, and I set ranges for each of them, and I receive an email twice a day if they exceed or go below those ranges. Most doctors are not going to do that. I guarantee you. One thing, they're not going to get paid for it, and two, they haven't bought into this as of yet. In other words, how many hours a day do you spend looking at this information and discerning from it? Also, most doctors don't have the infrastructure, the research infrastructure that I have to assist me. I have the patient's information. I could call them, but what I do is I push 2 different buttons, and I have a set algorithm of what to tell my clinical nurse, who gets an email back on her phone, and then she calls the patient. Saves me time. It works all over the world, too. Yes, sir. Come up to the mic.
Please feel free to announce your name when you come to the mic, so all the nano apples, which are going to, orchards of nano apples, which are going to grow from these nano seeds, know from whence they came.
Well, I'm Stephen Lee. I'm from Ohio State University, and your comments suggest that there's a political dimension or a sociological dimension to this,
Definitely.
Which has to do with the mechanisms by which we pay physicians. And so what you're talking about is instituting a care model that fails to pay the piper for many of these guys. And so that's probably going to be a tough sell.
It will be.
So would you comment about what sort of changes need to occur before this can be successfully implemented?
Well, unfortunately, physicians are adept at skirting around rules in terms of what they can get paid for. I just saw a report by the AMA. They were actually bragging that 60% of doctors in the United States give away free care. 60% of it. Only 60%? I mean, what the hell is this? Why would you brag about that? It's crazy. That being said, for this model, I see a reimbursement rate based on a monthly, if you will, payment for doing the review, which is higher after either an event or the implant, and then becomes progressively less as you hopefully make a patient get within a certain range, with bonuses for a patient doing well. Because one problem we had with the COMPASS trial was that despite my best efforts at 29 centers, 12 of the centers put the devices in and never did anything. They got the information but never acted on it, even though one of the check marks was, I have followed the care guidelines. That was just a check mark, whether they did or not. For example, at my institution, in the control group, the event rate per 6 months was predicted to be 1.8. Just in the control group, it was 0.9 hospitalizations per patient, because we follow our patients very carefully. In the active group, where we're looking at the information, it was 0.2. So 0.9 to 0.2 is statistically significant just in my 29 patients. In over half the groups, there was no change between active or not. And if you look at what they did, yeah, they had the information, but they didn't do anything. So again, this is giving us diagnostic information. It's not treating the patient.
So Bill Dinan, Medical College of Georgia. So our
And many of these institutions were in these studies with me, by the way.
That's great. I hope we were, but I don't know who at our institution would have been. We do serve a population that's perhaps similar. It's rural. It's underserved. A lot of burden of chronic disease. And there's a group of people in our healthcare system and in our school that have followed what seems to be a different path, which is establishing a center for patient and family-centered care, sort of with the hypothesis that drawing the families in improves outcomes, which it does. And I'm wondering if there's a way that one could meld this very intensive high-tech approach, which, as we've heard, suffers from the not being enough physicians in the whole world to really monitor and use this data, with the idea that you could make it more self-sustaining by having the patients or a family member be able to do a lot of this follow-up, a lot of looking at the data.
Indeed, that is the model we used in the studies I described. We start simple. I see these implanted devices being used on a small minority of patients who have the disease, less than 10%. The very ill ones need such monitors. The companies would like to put it in everybody, obviously, because they cost about $15,000, $20,000, but only a small proportion need it. And indeed, if you get the family in, you give education, and you assure compliance, that's the key. Even with this, having the information that the patient's not going to do what you ask them to do, for whatever reason, outcomes are going to be poor. In fact, non-compliance, either with diet or medication or other things, is the #1 reason for hospitalization in cardiovascular disease. People just don't listen despite our best efforts. And quite frankly, our current fee-for-service environment in the United States doesn't promote that. The more you see them, the more you get.